Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello, my name is Venk Palamganda, and welcome to the mid-April episode of Always on EM. This is the Grand Rounds portion of the show, where Alex Finch and I share one of the great talks we have experienced at Mayo Clinic recently. This one is from Dr. Mike Wilson, who was an outstanding visiting professor from Arkansas, and his full introduction will follow shortly. He gave a talk entitled, What Your Psychiatrist Isn't Telling You About Suicide Prevention in the ED. This particular talk is really important for several reasons. It begins with the fact that more people in the community are struggling with mental health concerns, in particular, mood disorders that result in more people having suicidal thoughts than seemingly ever before. Furthermore, his talk is very pragmatic. Immediately after listening, you will be able to help the person in front of you without needing expensive hospital-based changes. Also, his talk is backed by the best available evidence in the literature today. Of course, the literature always evolves over time, so the value may change as time goes on, but we live for today anyway. On a personal note, I originally matched in psychiatry before reimagining my life in emergency medicine. Of course, this is a much better fit. However, the people of the world that need mental health assistance will always have a special area of empathy in my heart. In addition, this chapter of the show is dedicated to the 5 people in my work and home life who have died as a result of suicide. I wish every day I had known about their suffering and had known how to be there for them. In their honor and in this noble purpose, let me transition the floor to the legend Dr. Chris Carpenter to do a more complete introduction of Dr. Mike Wilson.
It's my pleasure to welcome Dr. Michael Wilson, good friend, colleague, national leader in this area that we're going to be talking about today. Give you a little bit of his background. It takes a while because it's a pretty impressive background. He's a tenured associate professor at the University of Arkansas in Little Rock. He obtained his MD PhD degree from the University of Illinois at Urbana-Champaign. His PhD was in the Department of Psychology, Brain, and Cognitive Division. He did his residency after that at the University of California, San Diego, followed by a clinical research fellowship at UCSD. He arrived at Arkansas in 2017 and quickly became a leader in the psychiatric emergency care field as the director of the Behavioral Emergencies Research Lab there at Arkansas, and that's within the Department of Emergency Medicine. Nationally, he's current chair of the Coalition on Psychiatric Emergencies and an ad hoc reviewer for the Neurological Sciences and Disorder Section C of the NIH. In 2023, he received the American Foundation for Suicide Prevention, American College of Emergency Physicians Innovation and Acute Care Suicide Prevention Award. He's the principal investigator or co-investigator of over $3 million of federal funding projects, including funding from NIMDHD and SAMHSA. He has 88 peer-reviewed publications and has published 5 textbooks and 28 textbook chapters, including the ADEPT tool for managing behavioral emergencies in older adults, as well as the iCare 2 mnemonic for suicide prevention in the emergency department. As we warm up this topic today, just remember that psychiatric patients continue to increase in volume over the last 20 years, while the number of inpatient psychiatric beds contracted by 62% from 1970 to 2003. Psychiatric patients boarding in the ED remain in the ED for an average of 3 times longer than all our other patients. And an ASAP survey of emergency physicians in 2017 noted that 80% of emergency physicians noted an increase in psychiatric patient boarding, and 90% noted an association between boarding and episodes of violence in the emergency department. This is a vulnerable population with lots of opportunities for practice improvement within the emergency department and outside the emergency department that's going to be present throughout the rest of our careers. Thank you, Mike, for being here.
Oh, thank you. Wow, thank you for that incredibly awesome introduction with lots of cool adjectives. I really appreciate it. I'm going to pay you back that money I owe you now for that nice. Anyway. So like Chris said, I'm Mike Wilson. Please ignore the title slide. I am a board certified emergency physician. I will speak too quickly and use way too many pictures. Do I have any psychiatry colleagues in the audience today? Okay, thank you for coming. And I'm proud to represent, as Chris mentioned, a couple of really important organizations like the Coalition on Psychiatric Emergencies. It is the world's largest coalition of about 9 of the biggest groups in the country, including ACEP and the APA, and also the American Association for Emergency Psychiatry, which all of you should be members on. All right, we're going to try to do this super informally. So if you have questions, please don't feel like you have to wait. Here we go. There we go. Please feel free to stick up your hands if something that I'm saying doesn't seem right, okay? And let me adjust this and I can come out a little bit and talk. All right. Also, disclaimer. I know that universal screening is a very controversial topic, and I know that a lot of what I'm going to say about management of suicidal patients is very controversial. So please save the vegetable throwing for the end. I'll give you my email. You're welcome to flame me there or on social media if you feel like something that I am saying is wrong. I will also apologize to our very brave, courageous, and lone psychiatry representative here for much of what I'm about to say. All right. Is any... That's awesome. All right. Does anyone know who this guy is? Anyone? Okay. This is Dr. Ed Boudreau, probably one of the most famous suicide researchers in the world today. And he's at the University of Massachusetts. And he's done a lot of the work. I'm not going to present you his whole catalog, but he's done a lot of stuff and is also the only suicidologist I know of who's been covered by the Washington Post. And I love this picture of Ed because he's standing there in a tie in the middle of a trauma bay, looking, you know, very dapper. And this reporter contacted Dr. Boudreau to talk about the suicide epidemic. And here's what Ed Boudreau had to say. He said, it should be a no-brainer. His words, not mine. You can save hundreds of lives doing this, but the amount of pushback has been frustrating. And then they go through this, this reporter went through and interviewed a couple other people, and finally they made their way down to an impertinent, at the time, assistant professor at the University of Arkansas. And I said this, look, I happen to be a fan of screening, but the question is, how do you treat people once you find out that they want to hurt themselves? You can't just screen and send them out the door. And I said, look, as it is, there are typically a lot of bad options. You have to decide whether to hospitalize folks, which constrain your resources, even here at Mayo, but especially where I work, where we have no beds. And then I said something which I'm still amazed I came up with. I promise I was sober at the time, just wandering around in my closet while I was talking to this reporter. I said, look, focusing on screening is a little bit like worrying about the lawn catching fire when the house is burning down. All right. Now, if that didn't convince you that this conversation is important, let me give you some stats. And these are older statistics, as you can see. This is stuff in the 1970s, but we have every reason to believe that it's probably even worse today. And that is, patients are going to come to the ED. Okay, you know that already. Your volumes are through the roof. But especially, I mean, mental health patients. And we know from an article published last year that about 10.9% of all the folks coming through your doors nationwide are emergency mental health patients. Think about that, about 1 in 9 now. And usually when I throw out that statistic, people go, wow, that seems really low. Okay. Anyway, but when they looked back in the 70s, this is what they found, that a vast majority of people who died by suicide saw a physician within 6 months. And over half had seen a physician within a month before suicide. And over half of those folks had evidence of depression, but only a little more than a third were diagnosed. So this is our answer, this very old data, for why you can't just build crisis response centers and keep folks out of the ED, right? Which has been seriously proposed, that if we just had a better funding of outpatient crisis resource centers, they would never be a need for these patients to come to your ED, and certainly seemed to not work out so well for the pediatric patients and the cardiology patients and pretty much every other type of patient that I can see. And I suspect it's not going to work out here either. Patients are still going to come see you. And when they do, the results can be disastrous. Now, this is a study by Goldman Mayor out of the whole state of California. And they asked a simple question. When you show up at the ED with a suicide attempt or with your suicidal ideation, what are the chances within 12 months that you will have died, both by suicide and also by any other reason? Okay, and here's what they found. This was some older data. I believe they looked at 2009 to 2011. But again, it's the California OSHPA. It's the entire state, which is registered in a database. And if you visited for a suicide attempt, you were 57 times more likely to die by suicide within 12 months after your ED visit. If you just came in with ideation, you were 31 more times likely to die by suicide. And that's compared to the California population. Now, I knew I was going to be speaking in front of Chris Carpenter and Fernando Bololio. So who would have said, look, we don't care about the California population as a whole. We want to know about the other ED population. So this line is for them. And the answer is 30 times and 16 times. The rest of you can forget I said those last two numbers. Okay. Now, this is some of our own work a little bit later. We did something similar. We looked at all people who had died in San Diego from 2007 to 2013. And we have a unique system in San Diego that the medical examiner determines the cause of death. So we accepted that as the gold standard. And then we linked folks back to my EMR and just asked the simple question of how many folks were seen at UCSD, which turns out is a minority of folks because there are other hospitals in the area, but how many folks were seen at UCSD? And then where were they seen? Where was the last time they were seen before they died by suicide? And you can see there were a ton of deaths over that time period in San Diego. About 33, 37 of those were suicide, and we could link those back to folks that had a healthcare encounter in the at UCSD in the entire system, and about 281 of those. We excluded you if you died during the only encounter or if you had encounter greater than a year before death. And so that left us with about 224 patients. And here's what we found is that a lot of these folks actually were last seen in clinic. And that may just be because the system is changing, or it may be something weird about UCSD. But here's another thing to draw your attention to, and that is look at the number of weeks since your last encounter to suicide. And that risk stays pretty high over the subsequent 3 months after you were seen somewhere, but it's really high in the 3 to 5 weeks or so after they see you in the ED, right? Really high. And then it kind of gets a little bit less over time. Now, lest you be thinking that these were all the frequent flyers that you know, no. In fact, 42% of them had 0 visits, and the majority of them had either 0 or 1 visit. These were not frequent flyers. These were folks that came in for some other reason to see you. Now, what I want to ask now is, and in some ways it's a little bit of a clickbaity title, so I apologize to our psychiatrist in the room, because I'm sure the Department of Psychiatry has been trying to tell us these things sort of nationwide. But we've been fighting as a profession about things like universal screening. Okay? And I'm not going to solve that. I'm not going to resolve that debate today. But I do want to talk about things that we might be missing. We might be missing if we are actually focused solely on whether we should be screening people at triage. So Now let me get very controversial and really oversimplify everything that happens in the ED and just talk about the typical process. And so, you see a patient that gets screened, you quote unquote medically clear them, even though I have been on a decade-long campaign like Tintinelli to get the word medically clear out of our vocabulary. We still use it. So you medically screen them, you call psychiatry, something happens in the room, we're elsewhere, and then boom, they get a disposition and we go, cool. Right? Does this sound familiar? This is literally the ED process at any place I've ever worked. So what is actually happening? And I think it's important to talk about because of the serious proposals of a lot of groups that Chris Carpenter has worked with, that since we don't really know what's happening in this box here, that we should just be able to screen them, see the patient, and instead of calling psychiatry, take some subset and go right to a disposition. All right. First thing I want to say, let's talk about screening. And I'm going to just admit right up front that if you go to the literature to fact check me after this talk, you will find out that a lot of people use the term screening differently. And I know that because I just thoroughly, in preparation, because I knew I was going to, again, be here in front of Doctors Carpenter and Bololio, I just went with the over the new document by the Emergency Nurses Association last week in preparation for coming here. And I had a nice long conference call with them about suicide risk screening and suicide risk assessment. And it turns out they use those two terms interchangeably just last week. If anybody heard of the Manchester self-harm rule, that occasionally comes up. Chris has, yeah, don't use it. But if you read their articles, they also kind of use the term screening and risk assessment interchangeably. So I'm going to give you my definitions of this, which I think are widely shared. Just know people use it differently. And the question about screening is there any actionable risk present? And already we get to this weird thing like, well, what do you mean by actionable? Now, not at Mayo, but in places that I've been, what actionable risk means in some hospitals in, I believe, Oklahoma, is that they will have a police car come and pick you up and put the patient in handcuffs to transport them to a place so they can get mental health evaluation. That's what screening and actionable risk means to them. Truly outrageously offensive stuff that we still do in 2024. Sometimes people who also get confused by these definitions think that if they pop positive on a screen at triage, now they have to get one-to-one, all of the patients. And guess what? They run out of sitters very quickly in the ED. So that's not what I mean by actionable risk. What I mean is you need to ask more questions. And by the way, I stole a lot of this from our friend Ed Boudreau down here in an older article that he wrote with Lisa Horowitz, who created the ASQ, the Ask Suicide Questions, right, for kids. So here's what I mean by actionable risk, that you need to do what's called a risk assessment. And this is a more in-depth thing that your psychiatrists do an amazing job on. This is what they did their training on. And so they will ask things like risk factors and protective factors. And how many risk factors are there now for suicide? The last time I counted in the Jacobs document, it was well over 60. Do you know? It's dozens. He's refusing to answer. So it's oh, all right. Oh, so all right, you are totally in the emergency medicine. I love it. I love it. There's dozens. And then there are these protective factors, things that supposedly reduce your risk of suicide, social. And by the way, these are some of the biggest ones that I've listed here. So if you're talking about risk factors, previous attempts, a very strong risk factor that you'll attempt again. Your current mental state, access to lethal means, that's why we say ask about it. Substance use disorder, right? It turns out. And opioids, for whatever reason, amongst the highest risk for future attempts. Anyway, and then you have these protective factors, things like reasons for living and cultural, spiritual beliefs and something like that, or things like that. And then what happens is your psychiatrist somehow magically sort of weighs these things because by virtue of the board certification and the training they have, and they put your patient on this continuum of risk. Now, that process is not well defined, but we all kind of intuitively know there's a continuum of risk, right? So the guy that I saw about a year ago who was down in his basement putting a rope around one of the rafters in his basement, and they came down and his family interrupted him and took the rope away, and they brought him to the ED. We all intuitively in this room know that he's at higher risk than the guy in the waiting room who got bored with seeing other people go in front of him and endorse suicidal ideation. We know that. So we know that there's a risk continuum, even if we can't really define it very well. And the question is, how do you put people on this continuum? And as you heard, that may or may not be true, this idea of kind of weighting these risk factors, but at least how the APA, the American Psychiatric Association, thought about it in a very classic document from now 20 years ago, was that suicide risk can be formulated as an interaction between relatively stable risk factors or predisposing characteristics and acute precipitants. And again, you have to be a very well-trained mental health provider to do this. And people have talked about raised certification standards for who does your suicide risk assessments for this very, very reason. All right. And then again, at the end of this, you get somewhere on this continuum. And then in places that aren't Mayo, they do something that's even less well supported by the evidence. And that is they say, you're on this risk continuum and we're going to draw artificial strata in here and say that you are at high risk or low risk or somewhere in the middle, and we'll call you intermediate risk. And I think it's worth pointing out that there are a lot of people who state you shouldn't even do this at all, except for one influential organization, and that is the Joint Commission, who in their recent national patient safety goals said that you have to do risk stratification for at least near-term events in the ED. And if you don't, you're not following Joint Commission standards. In fact, UAMS got in a lot of trouble for this. All right. So let me talk about, again, some things that I think are well supported by the literature. And the first is that screening doesn't help you with disposition. And then given that diagram that I just showed you, you're probably like, well, how could it? But people have made very serious arguments that it should. Let me tell you about this study. This is by my buddy Scott Simpson out of Denver. And he looked at, Scott is the medical director for the PES in Denver. And he looked at the Columbia Suicide Severity Rating Screener, which many folks really like in across the country, and there's good reasons to like it. I'm going to tell you some reasons not to like it, but just know that many people looking at other data have said it is a good screener. And what he did is he looked at folks who came into his PES with suicidal ideation who all got the Columbia, and then what proportion had suicide risk. And you can ask why the Columbia. And again, earlier evidence has shown that's nearly perfect sensitivity in some outpatient settings in detecting suicide risk. And so because of that, it's on the things that the Joint Commission recommend, as SAMHSA as well. I'll point out it's never been validated in the ED setting. But many people think that the setting you work in has all of the same operating characteristics as just a really busy clinic, right? So the fact that it's never been validated in the ED doesn't bother some folks as much as say it does me. All right. Now, here is the Columbia triage screen. And so you can see you ask questions 1 and 2, and then if yes to 2, you ask questions 3, 4, 5, and 6. If it's no to 2, you skip to question 6, right? And here is this low, moderate, and then if you turn out red here, you are high risk. And the Joint Commission says if your screener is telling you that someone is at high risk, then you have to give them a one-to-one sitter. You have to do it, right? That means that person has to be within 6 feet. You're nodding, I can see, yeah. You have to be within 6 feet of them all the time, even in the bathroom, right? And I'll point out that if you're thinking of using the Columbia, that if you have intention, you are classified by the Columbia as high risk. Now, Joint Commission itself only requires a one-to-one if you have plan and intent, but because the Columbia says intent alone is enough to get you at high risk, you're going to use more sitters than other methods of screening. Or you're going to classify people as more high risk than other screeners. That's just a side note. Anyway, back to the Simpson article. So they looked at screening data from adult patients' first ED encounter during 27-month study period. They excluded you if you died during the encounter or if you left. And then they looked at the state health department or recurrent visits for suicide attempt or self-harm. Okay. And then they just asked the question, what's the sensitivity? And if you can see, it's a lot of numbers. Again, these are for 2 folks in the audience. Please forgive me, folks who are not Doctors Carpenter or Bololio. But I'll point out here that the sensitivity gets a little better depending if you go farther out, right? That makes sense. This is death by suicide. This is death by any cause. And what you'll notice, though, is that the sensitivity for this, while better over time, is actually quite low, right? Now, those of you who are not doctors below their Carpenter say, but look, we care more about the negative predictive value. I'll just remind you that suicide is a relatively rare event and negative predictive values get better as the disease prevalence gets lower. So I don't make too much of that. And I'll just draw your attention to that. So the Columbia itself, not very predictive of what happens to the patient in terms of suicide or death by any cause. So what did they conclude? They looked at 92,000 patients, so a fairly large sample size, and found that the Columbia has fairly low sensitivity and specificity. By the way, other research I'm not going to talk about says, look, the Columbia is great if you're doing risk assessment. That's not what we're talking about. We're talking about screening here. Here is another study by our friend Ed Boudreau. And he looked at, you say, hey, maybe it's just the Columbia that missed all these folks. Ed Boudreau and his group, Celine Larkin and these folks, looked at a different screener, the ED-SAFE screener. ED-SAFE was that multi-million-dollar multi-site clinical trial in 2017. It's really changed how we think about suicide in the ED. I'm not going to tell you about all that. I'm going to tell you about this secondary screener for suicide risk. And again, I'll give you a little bit of methods. Doctors Bololi and Carpenter, you can catch me later for more. But for those of you in the audience, it's enough to know that what they did, they got prospectively 1,376 patients who came in with suicide attempt or suicidal ideation. And then they followed them for 12 months, right? Both by telephone and review of healthcare records, the National Death Index. And they just asked, can this suicide or can this screener predict suicide? And guess what? If this screener classified you as high risk, over half of people, and actually the numbers I'm going to show you in a minute is a little bit more than 52%, did have some sort of suicidal behavior within 12 months. So, wow, that's impressive. And then you dive into the numbers, and what I'll show you is if you're looking at their screener for high and moderate versus mild risk, wow, sensitivity, a lot better than the Columbia. Okay, a lot better than the Columbia. And down here at the bottom, they just looked at high versus mild, moderate. We're going to ignore that and just go high, moderate versus mild. But what I'll show you here on another table is that even folks who scored in the mild range, a significant proportion of them had some suicidal behavior, even the mild risk, within 12 months. Okay. So again, we're back to this continuum that we talk about high risk and low risk, but really should probably be talking about higher risk and lower risk, and what does that mean, and where are the cutoffs, what are the areas under the curve? I don't know the answer to all those questions because people largely haven't done it. So let's ask a different question. Hey, suicide's kind of a rare event. Hey, Mike Wilson, maybe some suicide screeners will help us predict what our psychiatrists will do. That seems kind of valuable, right? If we can predict not who's going to die, but what's going to happen to him at the end of the ED. And this is a study we did a few years ago. And I apologize, I was very poor at the time, so I wasn't able to fund a fully randomized controlled trial. So you're going to have to put up with a convenient sample. I apologize, but I did the best I could with the free labor I had. And what we did is we looked at 3 commonly used suicide screening tools, and we just asked, what's the sensitivity to predict admission versus discharge? And there are things that you might have heard of before. So the modified sad person scale, there's a study from the 80s that said it perfectly predicted what psychiatrists at UCLA would do. Spoiler alert, we didn't study UCLA psychiatrists, so it didn't work as well in our shop. But so the modified sad person scale, the safety or the suicide assessment 5-step evaluation and triage, and then our friend, the Columbia here, right? Okay. So we enrolled about 276 folks, and everybody got all 3 suicide screening tools. We rotated the order, so hopefully there was no practice effects. And about 30% were admitted or transferred. About 1% died by suicide that we could find within enrollment. Now, keep in mind, that's pretty high risk in suicide world. May not be high risk when we're comparing it to stroke or sepsis, MI, but 1% suicide's much higher than the base rate in the population. So we would have to call this a high risk group. All right, and then what did we find? We found that there was modest ability to predict the disposition of patients, and that screening tools should not be used in isolation to guide disposition. Now, that agrees with a 2017 ACEP policy, but I'll point out, if you're surprised by these results, don't be, right? Of course, screening, the information you get briefly at triage doesn't perfectly predict disposition and suicidal behavior. SIRS doesn't perfectly predict sepsis, as we all know, even though I wish it did. It's easy for me to remember those things, and now I got to remember SIRS, SEP3 with all of these lab abnormalities and little electronic decision rules that pop up, and it's really frustrating when I'm working in triage. But I'll also point out that the literature to date has been focused more on identifying high risk. Because if you know who's high risk, then you can, if you're doing the social work, wait, where did my social worker go? Right. Oh, there you are. Because if you know who's high risk, those are the folks you can follow, right? And presumably get more juice for the squeeze, so to speak, right? You can follow that group, maybe give that group the daily phone calls. And that's where the literature is right now in 2024. Not what you want to know, which is who's at the least risk that I can send home without calling our psychiatry service. Anyway. Here's a second point I'll make. If we sort of step away from risk assessment and talk about prediction of suicide, it's at best a coin flip and maybe worse, okay? This is a meta-analysis, by the way, by Woodford in 2019 that appeared in one of the suicidology journals. And they looked at accuracy of clinician predictions of future self-harm. And clinicians were anybody who was enrolled in these studies making predictions of future self-harm. And again, given my audience here at Mayo, I did put in the Prisma diagram, and I'll point out that there are very few studies on this topic. That is only, in fact, they only included 6. And another thing I'll point out, look at the setting here. Most of these are the ED, but they did include some psychiatric inpatient services. Now, that doesn't bother me on this meta-analysis, but if it bothers you that the setting is a little bit heterogeneous, I'll point that out. And the other thing I'll point out, a lot of these studies were done outside the United States. Look at that country code. Now, again, I'm not sure that psychiatry in the UK or Australia operates any differently. But again, I think this study is worth talking about because the conclusions are kind of interesting. And here's the forest plot for what they found by the studies about how well people predicted future self-harm. And you notice there's this one outlier right here. And that's that Cooper group in England that found that if you use the Manchester self-harm rule, it's pretty good, right? And since nobody but Chris raised their hand for the Manchester self-harm room, I'm not going to make you sit through that. Don't use it, is my opinion. But the rest of those folks, if you exclude them, the rest of these folks are fairly low sensitivity. And when you pool them, even including that Cooper article, they found a pooled sensitivity of about 31%. So meaning that if you used these to predict future suicide, you would misclassify nearly 70% of all cases. Their words, not mine. Now, the reason they thought that was important is not the reason you would think. I mean, missing things is bad. Okay, we can all agree on that. But that's not the reason they said it was bad. They said it wouldn't be allocated to receive aftercare aimed at reducing future self-harm. And it turns out our social work friends here in the front are probably our most important allies in reducing self-harm when they leave. And I'll talk about that in a second. I'll just point out, in addition to suicide prediction is often wrong, I can't tell you in response to a question that Chris Carpenter asked me now, oh my gosh, a year ago or more, what high risk means. And I can't tell you. I can't tell you what it means in terms of absolute number of deaths or attempts or percentages. I can't tell you that. Okay. And what is high risk in one setting like an ED may not be as high risk, right? So, or I should say, what is low risk in like an ED setting may be considered high risk in other settings. And I don't think things are well worked out in that regard. So again, why is this potentially bad? And it's not because it wastes your time. Okay. Although I get it. People are salty about universal screening. I go to the same conferences you do. People talk to me. But I'll just echo what Woodford said, that by focusing on risk estimation instead of risk reduction, your patients don't get the best care. And I'll explain a little bit what I mean by that in a second. The reason I think that is bad is that most of the best SI care, most of the best care for patients with suicide ideation comes from you. And again, all due respect to our amazing psychiatry colleagues who may disagree with that. And that's because risk assessment is imprecise, and I think it's time to rethink what that means. I think what it means, instead of checking a box, I think you should be actively doing an H&P to use the skills that you already have, the conditions that can be treated to reduce risk, okay? Things like substance use. And by the way, I'll just say most risk, this is another thing. I often get this question. It's like, well, if we just had better treatments for our patients with suicidal ideation, and we do, actually, we do. Even though I can't tell you where on that hypothetical continuum they are, I can tell you that there is moderate level evidence now that you can reduce them wherever they are, reduce that risk by doing 3 things that are evidence-based, and that's safety planning, lethal means counseling, and then post-discharge care and contacts, with post-discharge care and contacts having a particularly marked thing. And that's why your social worker is so so important. When we're talking about solutions, Chris nicely mentioned the iCare2 mnemonic. The link for this is on the Coalition on Psychiatric Emergencies website. And basically, the iCare2 is a hokey mnemonic that put together a rigorous systematic review and said, this is how you should be managing the steps that you should be managing your suicidal patients. You should identify them somehow, whether or not you're doing universal screening. You should communicate with them, assess for life threats. This is what you guys go to residency for. You're excellent at this. Some of the best in the world. I promise you. I've given this talk overseas. Your ability to assess for life threats is amongst the best on the planet. And then this risk assessment that we're probably still going to need help with our psychiatry colleagues from because they have the training and the expertise. But then we kind of drop it off there. We don't often do things that reduce the risk, and we, in most places other that are not Mayo, I should say, that are not Mayo, we don't extend that care beyond the ED. Now, if you're wondering where we got the iCare2 mnemonic from, it was a collaborative effort between ACEP and the American Foundation for Suicide Prevention. It does, and I can tell you this because we did a systematic review on this, it does have the greatest adherence of any published guideline to Institute of Medicine criteria on how you should do clinical guidelines, okay? And sometimes our psychiatry colleagues, when I go to psychiatry conferences, I've actually spoken at the APA a couple of times. And sometimes they get a little salty with me and they say, why are you emergency physicians being so resistant to making the changes that we know will save lives? Kind of like that Ed Boudreau quote, right? It should be a no-brainer. Why are you people pushing back? And this is my answer here, this slide, that things haven't been done, guidelines haven't been made in a rigorous enough manner for emergency medicine clinicians to change practice. And we know that now because a lot of these other non-EM guidelines didn't really adhere to the Institute of Medicine criteria. Okay. Here's what iCare2 looks like. And if you go on the web page, I think they moved it to a new platform, so I don't know if the colors are still there, but it still looks like this. And you have these buttons, identify, communicate, assess, right? And when you click on it, you get a drop-down menu. You can look at this in the middle of a busy shift. It was designed to be for emergency physicians who are busy. Our volume's a little less than yours, but so is our staffing, so I'm just as busy as you are. Anyway, I'll point out here another reason not to rely too heavily on your screening tool. Screening tools miss a lot of things because they don't capture and can never capture, just like a probability that your patient has a PE, they cannot capture your gestalt and clinical knowledge. And so how many of you, the last time you had an overdose, asked your patient whether they had thoughts of suicide? And if you haven't, I'll just tell you that when they did a sample of folks who overdosed from opioids, more than half of them reported a wish to die before their last overdose. But that's not on any screening tool that I'm aware of. Neither is a single car motor vehicle collision. I've never heard that asked in my trauma bay. Now, we recommend, not just because I happen to think Ed Boudreau looks good in a tie, although he certainly does, but because I think it has the greatest evidence, we recommend for screening his screeners, the PSS-3, that's that screener, and then the ED-safe secondary screener, which is confusingly called a screener, is actually that assessment and risk stratification piece that the Joint Commission makes you do. All right. Now, if I haven't sort of hinted it enough, why I think you should be doing good identification in the ED is to find problems to fix. Starting Suboxone is well within your skill set. Managing, helping them get their diabetes under control, well within your skill set, or at least to refer them to folks who can follow them. These are things we do every day. both of them highly correlated with risk of future suicide. So by doing the things that we do best, we will make our patients better. By the way, if I was doing this at the APA, I'd call these modifiable risk factors, right? But that's what we're doing. We're just doing our jobs to make people feel better. All right, back to back to the iCare 2 tool. If you're interested on lethal means, yes, it is more than saying, do you have a gun at home? Okay, I mean, that is an important part of it, but it's more than that. There are courses on here that you can click on, particularly this CALM training, counseling on access to lethal means. And probably one of the biggest things that most folks who are not Mayo are not doing, and that is safety planning. And I understand you guys are, and so I want to actually kudos to you guys for doing safety planning regularly. Less than 1 in 5 emergency departments are doing this across the country. Just so you know, we know that because Mark Olofsson did a nice study on that. And he found out that less than 20% of EDs across the country are doing any element of safety planning, let alone the whole thing. So we know that everywhere else you go after this, nobody's doing safety planning, but you should be. And there is the link to the 2 most popular safety plans. This is the Stanley Brown that you guys use here. And this is ED Safe, which was that big multi-center, multi-site randomized clinical trial that I told you about. All right. If you've never seen a safety plan, here it is. I'm not going to take you through it. It is underwhelmingly simple. I am showing you the entire thing. It is 1 page because the magic, by the way, is not in a piece of paper, as you've probably already guessed. It is coaching your patient through the steps to be able to fill this page out on their own. So if you fill it out for them, you arguably done nothing but waste both of your time. You really have to coach the patient, and that's why you're not going to have the time to do it. But high quality safety plans cut risk of dying by suicide, in the best evidence that we have, cut risk of dying by suicide by half. Everybody should get a safety plan before they leave. And I believe we should be calling them up if you have the resources and helping them modify that safety plan after discharge. All right. Now, here's another thing that you probably are wondering, well, I don't have time to go and do a safety plan. And of course you don't. You do not. Even in the ED SAFE study, they didn't have the physicians doing this. But also, safety planning can be done by non-clinical staff. And at the Virtue, since we were the only ones so far, I'm going to show you our data. And this was a randomized clinical trial that we conducted a couple of years ago at UAMS. And it was a small randomized pilot trial because the IRB thought I was crazy. Their words, not mine. For wanting to do a clinical intervention with non-clinical staff in the ED on folks on the worst day of their life. And basically what we did, we took people with lived experience who are also Arkansas certified peer supporters. So they had formal training, and we taught them how to do safety planning. And then we randomly assigned patients either to safety planning with our psych nurse, our poor overworked psych nurse or social worker, or a peer with lived experience or had been through a suicidal crisis themselves or with someone that they loved. And again, lots of numbers for Doctors Bololio and Carpenter, but I'll draw your attention to this one, this box at the top, that if you got it from a provider, a clinician, that the quality wasn't quite as high as if you got it from the peer. Now, notice on the scale, our peers clearly had some room to improve too. We noticed that, and so we made some effort to improve. But the point is, it was more complete from the peer. The plan quality was higher if you were the peer. And also, so was the time to make a plan, not surprisingly. However, it did not affect the time to disposition. How could it, right? Our peers didn't have any other clinical duties. But what it did do, notice here that although the groups are equivalent at baseline, as you would expect given a good randomization, the the folks in the peer group visits before the previous 3 months before the safety planning dropped in the peer group, but not in the group that saw the provider. And so when we did some fancy statistics, that decrease was significant. So what did we say? We said, well, compared with participants who got it in the provider group, the peer-delivered group had higher, similar lengths of stay, higher completeness, higher quality. I didn't show you the acceptability data, but it was similar across groups. And participants receiving peer-delivered planning had significantly fewer ED visits during the 3 months after safety planning. Now, again, I apologize. It was a small study, but not my fault. I asked for a lot more participants. The IRB was quite salty with me about that, and we got the participants that we got. All right. This, by the way, this randomized trial, which was the first to show that non-clinical peers could do this, got us the the American Foundation for Suicide Prevention Award that Chris was talking about. My colleagues love this picture because they have nice pictures of them and I'm covered up by all this text. So next time I'll remember that it should be, my face should be up near the top. That's what I learned from this experience. Okay. Let me summarize and then I'm happy to take some questions. Here's some stuff I think we're not really talking about, and that is the best reason to screen and assess. People always ask, do you find more patients with suicidal ideation in universal screening? And the answer is, of course you do. The clinical significance of the patients that you find with that screening is completely unknown. It's completely unknown. So I can't tell you that these extra folks that you're finding, you're going to save a life, but I can tell you that if you do good screening and assessment, you're going to find things to treat that keep them out of the ED. Also, if you are going to screen at triage, use a standard screen. If it's not the PSS3, use a screener of your choice, but don't use unstandardized questions. We know those are not helpful. So the standard one I always hear is, you don't want to kill yourself, do you? Okay. Guess what? That question doesn't work as well as the one that's been studied. This is, again, an evidence-based point for Doctors Bololio and Carpenter. You have to ask the things as they were studied in the studies. So they have suggested language, use it. Risk assessment is improved by validated tools. If you want to try your hand at risk assessment before your psychiatrist gets in, so you can figure out exactly how long it takes, grab a copy of the Columbia, go through those together and then, or go through those questions together and then ask questions about some of the biggest risk and protective factors, right? Things like that substance use disorder that you didn't know you had. But don't use these to decide who goes home. Not yet anyway, not in 2024. You will get burned. There are things you can do. There is moderate level evidence, at least one systematic review by Nuji that's looked at this and which I didn't present to you, but safety planning saves lives. It may not do anything for suicidal ideation, but it definitely reduces the number of people who die. Please do lethal means counseling. If you don't have time to do all of it, at least ask them about guns, right? Guns are involved in over, anyone remember how many suicides in the United States? Well over 50%. So ask about guns or whatever means they've identified to you. Social work is your best friend. We know the evidence is a teensy bit mixed, but supportive of the idea that if you contact people after discharge, you will save lives. And it actually doesn't matter. We were talking about this at lunch. It doesn't matter how you contact. It doesn't matter. They've studied phone. They've studied text. I've studied carrying letters. And you go, come on, a form letter works, right? I throw that in the garbage. I'm telling you, it works. Just knowing that somebody is out there who cares about you. And of course, don't forget about the mental health resources too. But these are the things that save lives. All of these are evidence-based, I promise. Links for them are on the coalition website. Don't worry, by the way, if you do lethal means counseling, that you put the idea in their head. You won't, okay? But do ask about guns. And with that, this is the last slide. I've given you some QR codes from some of the organizations that I've referenced in this talk. So the Coalition on Psychiatric Emergencies on the right, that QR code will take you to the website with all of the resources on there. There's tons of podcasts and webinars. The American Association for Emergency Psychiatry, for those of you who want a much deeper dive into this. I'm looking at you, Sarah. Yep. You should join this organization. It's great. They have both emergency medicine folks and psychiatry. And this is my email. So if anything I have said seems wrong or not evidence-based, or I want you to reach out and flame me there first before Twitter. Mostly because I gave up using X, and so I won't know if you're flaming me there anyway. So you might as well do it in person. All right. And with that, I'm very happy to take questions. Everyone's like, can you go over the definitions of screening and assessment again? That seemed to be a popular slide. I'm sorry, Chris, go ahead. I'm kidding.
Wondering, so the ASAP Clinical Policy Committee, as you know, we do have a psychiatric emergencies clinical policy. We're building a new one right now. There seems to be in our specialty huge blind spots with this population and this problem. Biases too, cognitive biases, that this shouldn't be our responsibility. And the inertia to, like Dr. Boudreau says, fighting tooth and nail that we're not going to deal with this because this isn't our job. And then along with that, once you start to overcome that inertia and start to actually think about the problem in the population, that there's a sense that we just jump over the logic that you just painted for us. We can identify ankle sprains and neck injuries, head injuries with clinical decision roles. We should be able to do the same with psychiatric emergencies and just quickly move to disposition after a couple of questions with a well-validated tool, which you just pointed out is probably a logical fallacy and maybe an impossible mission. How do we start to fill the gaps in knowledge and these cognitive biases that are precluding more rapid progress?
Wow, that was a very large question. So responding to first things first, look, and I mean no disrespect to this lovely audience and folks on Zoom, but most of you don't like mental health patients. Okay, you don't. We know that. We've done surveys. I've spent the last decade of my life traveling around arguing and advocating for better care of emergency mental health patients in this country. And I know that a majority of EM physicians are sort of tuning out. Okay. So whatever your reason for coming to work is, whatever that is, remember that one of the biggest things that you do is alleviate pain. And pain in a mental health patient, while you can't see it because there's no bone sticking out, is no less real than what you're doing for every orthopedic patient. That's the first way I would answer that. The second one is, look, we may get to a low-risk suicide pathway, just like we have a low-risk heart score, right? We may get there. In fact, you and I should collaborate on this. It could be great. But right now in 2024, the literature to date has been focused on the other end, the high-risk end, so that we can tell our awesome social work folks who to follow. That's not an uninteresting question. It's a great question, but it also doesn't get us closer to what the question you just asked. And we have this sort of logical assumption that if we identify this high-risk group, N, let's say, then 1 minus N must be safe to go home. And that's not probably true. There is probably a very low-risk group out of this that we don't know quite how to identify yet. And even if we do identify them, and some people have have. There was an article by, again, our friend Boudreau in, oh my gosh, I want to say the late 2010s, 2016, 2017, 2016, that did identify a very low risk group that even Ed Boudreau thinks can go home without mental health evaluation in the ED. Guess what? Two problems. One, it was less than 1% of the patients in that study. Okay. And two, they did something for them before they went home. So they stopped trying to worry about where they were on this risk continuum, and they actually did safety planning and lethal means counseling. And then they followed them up after they left the ED. And guess what? If we're going to do that, if we're going to invest that kind of resources, yeah, there probably is more than 1% that folks that could go home and see their psychiatrist tomorrow if we could get them in. But we just don't know who that is yet. But you and I should definitely talk. I'm sorry, go ahead, Venk. Yeah.
We have two questions from folks online. Dr. Staub first, and then Dr. Johnson.
Mm-hmm.
So, Dr. Wilson, thanks for coming to be with us. I'm Jeff Staub. I'm the chair of psychiatry and psychology here, and worked in psychiatric ED at the University of Pennsylvania for 10 years before coming.
And by the way, thank you for attending. So hopefully you were not one of the psychiatrists we offended during the talk.
Oh, no. I'm much tougher than that. I've been a psychiatrist for 35 years. It's, thick skin developed over the years. So just a couple of quick comments. First, I really want to emphasize what you said about the Stanley Brown and safety planning. Stanley and Brown did not invent that process. They just copyrighted it. I was taught that 35 years ago.
Oh, okay. Okay.
So the process of asking people, who are you going to contact? If you're kind of feeling mildly bummed out, who are you going to contact if things are a little bit more intense? That really is meaningful. And not only in giving something to the patients for them to take with them, but also a little bit further assessment of how much risk mitigation is available to you right then and there in the emergency setting. Because if somebody can't complete that, then you really are at a spot where they don't have a lot of mitigation opportunities, and you have to think about other potential interventions. So again, that approach that Stanley and Brown copyrighted, been around a long, long time, a very reasonable way of doing it. The other thing I would teach my residents, both emergency medicine and psychiatry residents, is that if somebody comes to the ED and says their life that they're suicidal, risking potentially getting locked up in a psychiatric unit that day, their life is pretty crappy right then and there. And that kind of taps to the comment that you made about our real goal is reducing distress. And so when I'm doing a suicide assessment, I'm not trying to predict who's going to live or die. I'm really trying to predict what level of intervention that person needs to bring their distress level down a couple of notches. And that's why when the studies on outcomes focus only on suicide deaths or suicide behaviors as an outcome, that would be analogous to saying that the only concern that we have of a person who comes to the ED with chest pain is whether they die of an MI, and we don't care about other outcomes. So I think that we're always going to get stuck on, like, as you said, those numbers on sensitivity and specificity, because death is a rare event. But rather, if we think that our goal is just to reduce that person's distress and suffering, get them to a place where they are not as where they can live a little bit more of a quality of life, whatever that may be, that's actually our best. That's actually what we're trying to do as an outcome.
I think that's very well put. I'm not sure I have anything to add to that. Sometimes I'll get pushbacks from my residents that say, well, that's not real pain. And I say, well, what is pain? It's to you. And for most of the folks that I work with, it's some sort of ability to look at the patient and see that they're suffering in some way. I hate to equate pain and suffering, but you know what I mean, that they're in some sort of pain. And that is absolutely no different with a patient with suicidal ideation.
Dr. Johnson?
Yeah, hello, Dr. Wilson. We actually met at LAC last year out in DC. I was a medical student. Sorry, I can't be there today. I just took
it's all right.
I just took step
are you going
3.
back this year?
Yes, so hopefully I'll see you.
Okay.
So yeah, I just took step 3, so I'm a little dead. So I didn't make it. But, kind of as a follow-up to Dr. Saab's question, with the safety planning, I was just wondering, is there, with your crazy IRB, like, is there any evidence that just having the patient have that level of kind of introspection and thought about it, just thinking of, the resource issues and staffing issues in EDs around the country, is there any evidence that even having the patient sitting there and filling it out themselves, so given the time constraints that we have, that their level, and then you return back and kind of see the filled out form, and spending, if you don't have peers, you don't have, like, to have that they just took the effort to think through it, and you evaluate sort of instead of going through it with them in real time. Is there any evidence of that or thought of that, like, also being beneficial as a protective mechanism?
Sure. Let me make sure I understand the question. So instead of coaching them through the process, you kind of let them reflect on it.
Yeah. I'm just thinking of the time constraints, like you said, that's part of why I employed peers in this setting to help. Just thinking of the low resource.
Yeah. So usually, I'm not sure what you mean by that. Usually when people say that, they say, what would happen if I just gave them the paper and left them alone? Right.
Or even just came like back. I guess I'm just trying to think of the cutting time, like in a low resource setting. I'm from a rural area.
Right.
Maybe you're the only person there.
Right.
Yeah. And coming back and talking to them.
So, I can't answer that specific question. What I can tell you, there was a famous study by Gamara, I want to say 2015, in one of the suicidology journals, that looked at the quality and completeness of a safety plan and how likely that person was to either be rehospitalized or have to be admitted to the hospital or represent to the ED or die. And it turns out high quality safety plans matter. They have direct clinical outcomes on the things that we care about. And I suspect, even though nobody's done the study that you just asked about, I suspect that if we left that person to their own devices and just came back to check on them and said, oh, keep going, right? You're almost there. That we would not get safety plans that were as complete or as high quality. And that it's not just the act of doing it, right? I'll just say that again. It's not just the act of filling out that page. It is the cognitive steps of going through to plan what your patient will do when these thoughts recur, because they will recur. And that is the important ingredient. And so I suspect if we were to just sort of give them that paper, wander away and come back and check on them, we wouldn't get the results we wanted.
Dr. Wilson, I just real quick, this is just a comment specifically on Dr. Johnson's question. So sure. I actually do that sort of, but I sit down and say with them and tell them this is the kind of situation for line number 1. This is the kind of situation for line number 2. So line number 1 is if you're kind of distressed, who might you call? Line number 2 is what if that person's not there? And then sometimes do allow them to have some time to think it through, but come back though and sit down with them and go through it. So not just sort of here, fill this out. Oh, okay, that's good enough.
Right. Right.
But at least give them a moment to kind of think it through, because it really does help with the assessment. If somebody can be thoughtful and come up with reasonable options, I'm more likely to trust that it's meaningful and useful to them. Whereas if it looks like they either couldn't do it or just kind of gave it, short shrift, then we've got more work to do. So, but it is set them up properly, give them a little bit of time, and then come back and finalize it together. But it still is okay to get. I mean, just again, that's anecdote. That's not evidence-based outcomes. And it depends on some patients aren't in a state that they can do it on their own. But it's not a bad thing so long as it's just part of the full process of, as you said, getting a decent quality product at the end.
Yeah.
Right.
And
I think, go ahead.
Go ahead.
Barry. No, I was just going to say that is the right way to do it, right? However, you get a high quality plan at the end.
Yeah, I was to say, I think that's kind of what I expected. And I kind of was going to circle back then. My thought is if these things take the time that they do, and as they should, and to give quality care that we want, it seems like perhaps this is something that needs to be incorporated as a like billable item, right? In an RVU, like you're taking a tremendous, an appropriate amount of time to save someone's life. That I think that should be reflected, I guess.
I'm really excited about your data from the folks with peer lived experiences. And I know that was small. Is there any thoughts of doing it again larger or potentially externally validating or doing this in a multi-center way? And the reason that I ask is we have something similar for substance use disorders and have had really good luck with it. And there are peer specialists with lived experience trained by NAMI here in Southeast Minnesota that respond to our Southeast Minnesota Regional Crisis Center, that respond to our other community mental hospital in town. We have not done that here. But the quality of I guess not quality, credibility of somebody who has sympathy as opposed to just empathy, I think really is what you're measuring there. And that 31 patients is not enough to change practice, but what's the next step in that? Because I think that that's actually a huge thing. Did the IRB change its mind?
Sure. I think if we were to do it again, they would probably allow us. So the first answer to your question is yes, we have definitely thought about doing it again. And one of the nice things was the NIH picked this up. And so I got to speak at the NIH virtually, but at the NIH in one of their symposiums about a month ago on this, which was perfect because we were in the middle of putting in a resubmission on the grant for this. And unfortunately in NIH world, and again, I'm sure Drs. Ballou and Carpenter will sympathize with me, we're not quite ready to jump to the multi-site randomized clinical trial because they want to see some more work on acceptability and feasibility of performing the whole protocol. But yeah, there's reason to think that it would work. I mean, lots of reason to think because it worked in our setting and probably will work with more than 31 patients.
Thank you so much, Dr. Wilson, for the amazing talk. Really, it's a call to action for us all to reignite our empathy and care for this population of patients. We need to re-engage in the creation of safety planning and discussions about how we can make their lives better. To the Always On EM audience, Alex and I are forever grateful for your engagement. May 1st, we plan to continue with our next chapter. Thank you as always for listening to us.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.